Hello, and welcome to a Health Podyssey. I'm your host, Rob Lott. Today, we have another very special episode of the Podyssey, recorded with a live audience. This conversation, it's still fully virtual, but today, instead of just me and a guest on Zoom with our producer, Jeff, now, as we record, it's August 12th. We've got a whole crowd of listeners, and in a few minutes, we're going to put them to work by asking them to weigh in with their own questions. And I want to thank everyone for being here, especially our guest, Dr. Kenton J. Johnston, an associate professor at the Washington University School of Medicine in St. Louis. He is also the associate director of the Center for Health Services and Policy Research and director of the Medicare Innovation Research Lab. Together with his co-authors, Dr. Johnston has a new article in the August issue of Health Affairs, looking at changes in clinicians' participation across Medicare value-based payment models from 2017 to 2022. Of course, we've been talking about the move away from fee-for-service payment toward a more value-based payment system for nearly 2 decades, if not longer. But 2017 marked a really pivotal moment in that transition. And we're so fortunate that Dr. Johnston and his colleagues have been able to track and study clinician participation in these models from that point onward, and to do it with a longitudinal cohort. I'm really excited to learn more about their process and their findings here today. Dr. Kenton J. Johnston, welcome to a Health Podyssey.
Thanks so much, Rob. I really appreciate you having me, and I'm excited to be here this morning.
Great. Well, let's dig right in. And I thought I might ask you to start by putting on your historian's hat for just a moment. And maybe you could give us a broad picture of the value-based payment landscape in Medicare. And I was thinking we could sort of look at it in 3 chapters or chunks, if you don't mind. And so I might ask you briefly to tell us a little bit about three of those phases. And the first one might be for you to describe what things looked like in the early 2000s and the years before the Affordable Care Act became law. What was the value-based payment landscape at that stage?
Great. Well, that's a great question, Rob, and I appreciate you asking me that. I actually got my start in this field in the mid-2000s at Blue Cross Blue Shield. And, back then, in the mid-2000s, early 2000s, a lot of the issues that we're talking about now were talked about then at an earlier stage. And so, from really the late 90s, there was a lot of discussion in how much variation there was in the quality of care delivered across the United States, whether in Medicare or in private insurance, and really spotlighted, I think, by some reports by the Institute of Medicine. And then around the same time, the Dartmouth Institute really spotlighted the similar variation in costs of care, and variation that was not necessarily a good thing, either in costs or quality. And so, in the early to mid 2000s, a lot of healthcare payers, including Medicare and private insurance companies like Blue Cross Blue Shield, were thinking about, well, how can we improve the quality of care for patients while constraining costs? And so at that time, it was generally recognized that volume-based fee-for-service payment, there were problems with it. It was not incentivizing the best possible system, getting the most value for our money. And so some of the early programs that both CMS and insurance companies experimented were with like disease management or population health management programs, right? To manage chronic diseases like diabetes, heart failure, asthma that drive a lot of costs and for which improvements in quality could really also improve people's lives. And then around that time, maybe towards later in that decade, there was the physician group practice demonstration, And there was also, which is kind of like an early precursor to ACOs, and the emergence of the patient-centered medical home, which I believe started in pediatric care and then moved into care of adults. And so the idea was that physicians would begin to take more responsibility for the care of populations. I think by that point, disease management was promising, but by that point, the later part of the decade, people were starting to realize that it wasn't producing the outcomes that people were hoping for. Then there were a couple randomized trials that CMS conducted that were disappointing, that didn't result in quality improvement or cost savings like they were expecting. And so that kind of led into, well, what about accountable care and patient-centered medical homes? And then around that time was when they were drafting the Affordable Care Act. And so that kind of leads us up to the Affordable Care Act, a big picture.
Great. Well, yeah. So that's chapter 2 of this story. 2010, after that lengthy battle and a lot of work going into the development of the Affordable Care Act. March 23rd, President Obama signed the law. 2010. What happened then?
Yeah, great question. Well, a lot of times people don't think about the Affordable Care Act with respect to value-based payment as much as they do with respect to insurance expansion, unless, of course, you're working in health policy or an avid policy wonk or reading about health policy. But actually, the Affordable Care Act took a lot of what was already happening in terms of experimenting with value-based payment and provided a platform to test some of these models through the CMMI, the Center for Medicare and Medicaid Innovation, by funding that center in order to really test out a lot of different pilot programs of what were called alternative payment models. And some of those included accountable care organizations. And so you can think of the Pioneer ACO program was one of the first ones. Launched in 2012, and then the Shared Savings Program, which then became a permanent part of Medicare and is now the biggest ACO program. I think, probably two of the most important things that came out of that were the CMMI in terms of let's test a bunch of different alternative payment models and fund the CMMI to evaluate, implement, and test them. And then let's also begin implementing accountable care organization programs where groups of providers, physicians, hospitals, health systems take responsibility for a whole population of patients.
Okay, great. Well, that brings us right to 2015. Congress passes a bill known as MACRA, and then 2017, that implementation really took root. Can you tell us a little bit about what was behind that and sort of what things have looked like since then?
Yeah, sure. And so the way that Medicare Part B is the part of Medicare where people receive physician and other professional services. And, this is really where most people who are Medicare beneficiaries, they're going to use this part of Medicare regularly. I think the average beneficiary probably has like 10 office visits, what are often called evaluation and management visits annually. There's over 1 billion such visits. And so these physicians and other professionals were paid through something called the Sustainable Growth Rate formula. And the way the formula had been set up, Congress had to basically, it would have resulted in pretty big physician payment cuts over time. And so Congress always had to kind of reset that every year to add in additional payments for physicians. And so there was a desire to fix that. And then there was also a desire, and that was, under the fee-for-service system, there was a desire to systemize more participation in value-based payment. The other thing I had forgot to mention earlier was the value-based payment modifier program, which was a precursor to some of the one of the main value-based payment programs in the quality payment program. And so the QPP basically systematized all of this and made it mandatory for physicians to participate in some sort of value-based payment program as long as they hit a certain patient and service threshold in the Part B program. And so we can talk about what those different value-based payment programs are that are the topic of this paper. But I think the big thing to emphasize is the QPP essentially made it mandatory to participate in some kind of value-based payment program subject to volume thresholds, which, as this paper shows, are actually, hitting a pretty large number of clinicians now.
Got it. And if I might sort of take a step back, my sense is that sort of before this, clinicians, providers could sort of pick and choose and really sort of opt out of a lot of these models if they weren't interested. And this program really sort of tried to kind of steer folks into various programs that they might not otherwise choose to by shifting some of the incentives. Is that a fair description?
Yeah, it is. And, before this point in time, hospitals were required to participate in some value-based payment program, but physicians were not in the Part B part of Medicare. And so that is really, I think, what was new about the quality payment programs, had to pick at least one value-based payment program.
Okay, great. Well, that's really helpful background. And I think against that, we can take a closer look at your paper. Can you tell us a little bit about maybe your top-line findings? What are some key takeaways?
Yeah, I think big picture, what our findings highlighted are that there's a substantial chunk of clinicians who are participating in Medicare Part B, treating patients in Medicare who are exempt from the program altogether. I mentioned earlier there are these patient and surface volume thresholds, and so a lot of clinicians, and this is one of our big findings, this is growing over time, are completely exempt because they don't meet the volume threshold. And there are a number of thresholds, but I think the easiest one to remember is 200 patients approximately in a year. So there are a lot of clinicians who were not seeing at least 200 patients, but are seeing Medicare patients, and in the aggregate, they make up a lot of clinicians. And so that is growing over time. And so that's I think that's a big finding. There's no evidence that they're participating in any value-based payment program. And then we're seeing,
clarify, they may be seeing other patients, just 200 Medicare patients. Is that right?
Yes, exactly. Well, 200 patients in the fee-for-service traditional Medicare program. They may be seeing, many more patients in Medicare Advantage. But yeah, because we're talking about Medicare Part B, fee-for-service Medicare, it's 200 patients in that program. I think the other big picture findings, just thinking from, one of the things CMS is really focused on are increasing the proportion of beneficiaries in accountable care relationships, which a lot of people understand to be population-based models, such as ACOs, where provider groups are sharing insurance risk for the cost of care. And so we found that the percentage of clinicians participating in those kind of ACOs, it grew from 7% to 22% in this time period, which is good news, I think, from the perspective of what policymakers are wanting. However, when you think about it, 22% in those two-sided ACOs is, it's still a relatively low share of clinicians. The other big picture finding would be that the proportion of clinicians participating in what's sort of the default program. So if you don't participate in an ACO or another alternative payment model, and you're required to participate in the QPP, then you're going to participate in the merit-based incentive payment system, which is sort of like fee-for-service payment with some penalties and bonuses layered on top that have actually grown over time. And so in 2017, 46% of clinicians in our population were participating in what's called MIPS. And by the end of the period, just a little over a quarter were 26, 27%. And generally, MIPS is considered to be a very, let's call it value-based payment light, probably the least. There's something like 400 measures. You can pick your own measures. Probably the most gameable form of value-based payment. And so it's not really, if what we're wanting are people to be in accountable care relationships, we probably would want them to be in something more substantial than MIPS. And so, even as of 2022, almost 2/3 of the clinicians in the population of Medicare serving Medicare Part B patients are either exempt from value-based payment or only participating in MIPS, which again, that's probably not ideal. And if we want more clinicians participating in accountable care relationships.
Tell me a little bit about your reaction when you first kind of ran the numbers. Were you surprised?
Yeah, I mean, I think our first, the first time we looked at the data a lot because we're combining so many data sets. And so, validation of the data and understanding what the numbers were telling us. Honestly, I think the most surprising part of this, the increase in QPP exempt was not entirely surprising because clinicians' patient volume is decreasing over time in traditional Medicare. So as more of the population shifts to Medicare Advantage. And so that wasn't entirely surprising, although I think the extent to which that's occurring was somewhat surprising. The other part that I think was surprising that I haven't mentioned yet is there are all these other alternative payment models like patient-centered medical homes, bundled payment models that are collectively referred to as alternative payment models that aren't ACOs in our paper. And there's been a lot of time and effort spent on developing these programs. And, the proportion of clinicians participating in them is really so small. So less than 1% in 2017, and that grew to 1.4%. In 2022. And so I think that really was surprising to us as well. Like, hey, policymakers are spending a lot of time and effort trying to engage clinicians who aren't in ACOs in these other alternative payment models, and very few are actually in those.
Great. So as your findings suggest, CMS is going to have a hard time likely pushing more clinicians into the QPP in the years ahead. And I'm wondering if you can say a little bit about where we go from here, sort of what's the next step for policymakers at CMS, and if your paper were maybe to inspire some kind of specific policy change, what might you see happening?
Well, I think this is one area, Rob, where there's bipartisan agreement among policymakers, whether CMS from the prior to current administration or among policymakers in Congress, which is that a shift to population-based payment in the traditional Medicare program, so where healthcare providers are bearing risk for some of the cost of beneficiaries' care, that this is desirable, that this is good for the Medicare program, and good for constraining costs and perhaps good for beneficiaries. So from policymakers' perspective, I don't think the focus on getting more beneficiaries into accountable care relationships is going to change. The question, I think, is how to do that. And, if I were to give one piece of advice to policymakers, it would be just to do fewer things better. There are a lot of payment models. I think we estimated in the recent year, if we count all the different payment models just in the Part B program, and then within each model, there are different tracks. So there was something like over 30 options and that a clinician could choose from. And that's, when you think about it, the administrative complexity and cost of administering all those payment models and how they intersect with each other, because none of them are required, although you can choose among them, it's a lot. And so my recommendation to do fewer things better would be, why not just focus on a very small number of population-based ACO or global contracting type models, and try to do well in those.
Got it. All right. Well, let's turn to some questions from our audience. I've got a few in the Q&A here, and we'll start moving through those. One commenter asked, quote, I was told that because clinicians are not penalized for remaining in MIPS, more have opted for that versus investing in value-based payment, such as advanced APMs. And many APMs do not qualify as advanced APMs, including CMMI models. How is that affecting clinician behavior?
Yeah, so the person brings up an important point, which is the difference between advanced alternative payment models and just standard alternative payment models. Advanced APMs require some amount of risk sharing with CMS, like a two-sided ACO counts as an advanced APM, and physicians, get a 5% bonus for participating in those. The MIPS program is kind of like the default program. Like if you don't want to go through participating in another APM, you at least are going to avoid a guaranteed penalty by participating in traditional MIPS, and that penalty is ratcheted up to potential 9% of your total reimbursement, and so that's kind of like the default option. You can pick which quality measures you report on, and so if you're part of a larger group practice or organization, you can have your practice manager or health system figure out which measures that you perform best on, so that you can also avoid penalties there and get the exceptional quality bonus. Yeah.
Got it. And I guess I'll take one step back and say, what kind of interaction did you have with clinicians over the course of doing this work? And what have you heard from them sort of directly about how they feel about this program? I know I'm asking you to speak on behalf of all physicians everywhere, but I'm wondering if you can give us sort of a sense of the vibe.
Yeah, I think that's a good question. And now that I work in a medical school with a lot of clinicians, I think, I've been able to get a lot more perspective of clinicians on this. I think in general, anything that increases the administrative complexity of delivering patient care, clinicians are not going to like, particularly if it doesn't seem like there's a good reason for it, or that reason's not well communicated. So so in general, anything along this line is probably not going to be liked by most clinicians. I think that, the other thing here is that most clinicians today, in increasing numbers, belong to large health systems and group practices. They're not part of independent practices. And honestly, to be part of an independent, you have your own practice and participate in these kind of payment models, it just adds so much administrative complexity, so that, it's really going to be more of a headache to you. At least if you're part of a health system, you have an informatics and analytics team that can report on your measures as a group. Hopefully they're analyzing which measures you do best on and reporting them on your behalf. And so the other side of this is a lot of clinicians, like, this is sort of out of their control. And this is someone in the health system is reporting on these, taking care of it. That the bonuses and payment penalties happen 2 years later. So how is that really going to affect your practice of care? So there's, I think, a lot of like, this is out of my control. I understand generally what's going on. It seems like kind of an administrative pain in the way I practice medicine. But, on the other hand, I think there's also a recognition that healthcare costs are increasing. Eventually, I think it was recently projected it's going to be like, right now we're hovering close to 18% of GDP in the U.S. It's probably going to hit 20% by the early 2030s. And so there's a general recognition that quality and costs are not optimal, and so something needs to be done. The question is what?
Fair enough. We have a question from Jenny Brockman. She writes, CMS is interested in getting more independent clinicians into value-based payment models, But in our experience, they lack the funds to invest in the infrastructure needed to be successful. They don't have a health system or physician enablement entity behind them taking care of the data collection, reporting, et cetera, just what you were describing. What are their options other than consolidation, choosing to go with the big system? It just seems like an obvious disconnect.
Yeah, I think if I were advising or consulting with independent practices who did not want to join a big system, probably, the best thing to do may be so one of the things you can do with the merit-based incentive payment system is you can participate as a group. Well, if you're not part of a group practice, then you can form what's called a virtual group and participate that way. So where you group together with other independent practices and report your quality measures that way. And I would think that, the independent practices, you need some kind of support because it is complex. You need to have the management and information infrastructure to track and report measures. And so probably the best thing to do would be to go together with other independent practices as part of an association to do this together.
We have a question from Connie Damari. They write 44 out of 50 CMMI programs failed to lower costs. The MSSP breaks even. MIPS has not improved care and physicians are avoiding it. Patient access to care is declining. What is the evidence that value-based care should even be continued? Big question there. And a lot of claims from Connie. We're not going to sort of dig into the under the hood there, but how do you look at that big question? What's the future of value-based care?
Yeah, I think it's a great question, and I would have two responses to that. My first response is to frame this by looking at, well, what was the system? How was the system before value-based care doing, right? In terms of costs and in terms of quality, it really is what motivated the move to value-based payment in the first place, because a lot of people realized there were problems. But just because there were problems in the prior system doesn't mean the fix is any better. And Connie does raise an important point. All the evidence over these programs is not, it's not experimental in the sense of randomized trials. These are all observational studies, right? And so we have to take all of them with somewhat a grain of salt. The only randomized trials that that I can think of in the Medicare program, or I mentioned the disease management experiments in the late decade of the 2010s, and then they were published like kind of between 2010 and 2012. And that's an area where a lot of observational evidence had accumulated and initially was very favorable, and then as more rigorous studies came out, observational studies, people began to grow a lot more skeptical, and the randomized trials really found basically no improvements in quality or costs. And so I think Connie raises an excellent point that the evidence is not strong. It's very mixed. But we're also dealing with the real world, right? And so another recommendation to policymakers would be to encourage more kind of randomized trials like they did with the disease management and care coordination experiments. Right now, oftentimes this is kind of like very like trial and error. Like, what is working? Let's try this. And it's hard to get what's a good control group or counterfactual. What would have happened in the absence of this particular program? So I think Connie makes a very good point.
Okay, another question from Barbara Click. She asks, how can senior care provider organizations such as assisted living, skilled nursing facilities, memory care, how can they become bigger players in the broader population health reimbursement models? I assume she's speaking about senior care providers. We are underfunded and need more investments in our infrastructure. We know that there's a big Medicare spend in the last 6 months of life, and yet we are often overlooked as partners. How does that factor in?
Yeah, I think, well, under these population-based models, what's often referred to as the post-acute care area, so skilled nursing, home-based care, the sorts of things that the person with the question is asking about, are a substantial part of Medicare costs, and probably the best evidence for ACO savings has come in that area of savings in post-acute care. And so ideally, instead of spending time in an acute care hospital, someone would be in skilled nursing, or instead of in skilled nursing, they would be getting home-based rehabilitative type of care. But that really requires an ACO, an organization that has a span of control, not only over the hospital and doctors, but also some kind of partnership with these skilled nursing rehabilitative providers.
We have a question from Yvonne Banks, who asks, what are some of the key challenges that physicians, providers experience when participating in value-based care? And then I guess to bring us back to your research paper, I'm wondering if you can say sort of how you see some of those challenges playing out in the future. What do we expect clinicians' participation to look like in the years to come?
Yeah. I think one of the key challenges for clinicians is the relevance of the measures that they're being judged on to their actual practice, and are they actually under their span of control? For instance, a study that I did with some colleagues a few years ago, funded by the NIMH, we looked at participation of psychiatrists in the MIPS program, and we found their average participation was lower, for example, than other clinicians, and so they were more likely to get payment penalties and less likely to get payment bonuses. And when we kind of dug into that, well, what quality measures were they reporting on? They were things that had nothing to do with psychiatry. Things like cancer screening or cholesterol screening. And so the first question is, are the measures I'm being judged on even relevant to my clinical practice at all? And then are they something that are under my control? That the patient, who had their patients who had their colonoscopy screening, that was likely the recommendation of their primary care physician, not their psychiatrist. And so the question was, why are these some of the measures they're being judged on? And so is it relevant? Is it under my span of control? And does it help the patient? I mean, that's ultimately what physicians and their patients care about, right? The second part is, where is this going in the future? I think the likely answer to this is all of this is going to lead to more consolidation of physician practices within health systems. And that's been a trend over the past 10 years. And as administrative complexity increases, the costs of and management required to adhere to that increases as well. And so that is likely to promote a more consolidated health system.
Fair enough. Do you have a sense of the role of value-based payment in addressing things like rural physician shortages, rural healthcare challenges, and sort of how that's related maybe to the current payment structures in place?
Yeah, I think policymakers are a lot more sensitive now to investing in rural practices and providing more opportunities and or exemptions for rural practices and value-based payment models. In general, to the extent that a practice is under-resourced, being required to participate in value-based payment is going to be a burden to them. And so it's important to be able to support them, because the truth is people in rural areas already lack adequate access to care. And so we don't want to create more of a burden for the physicians and providers who are willing to practice in rural areas and are already burdened, or for, clinicians in high priority areas, like I mentioned earlier, like psychiatry.
Okay, fair enough. Can you say a little more about physicians and clinician groups that are, basically hospital employees or health system employees? Do you have a sense that they are, in particular, they are increasing their opt out of reporting MIPS compared to independent groups? And is the opt out related to resulting penalties for quality or because of the costs and of collecting data? I guess
Yeah,
the question is sort of, can you drill down a little bit into opting out versus exempting and the motivations behind either of those pathways?
sure. Well, there's not really an opt-out option in the quality payment program because it's a required program. There's more like an exemption. So if you don't hit the volume thresholds, you're exempted. If you're a certain type of practice or, during time of COVID, you may be exempted. There are some loopholes in that, in the sense that if you're, as an individual, you don't hit that threshold, you may hit it as a group. And depending on whether it's advantageous to you or not, you may decide to just opt out, in the sense that you're going to not report your individual measures because you don't hit the threshold. From a health system perspective, a physician is not going to be able to, assuming, as part of that, as a part of the groups hitting the volume threshold, which is very likely, and they're a qualified physician type, which is very likely, they're not going to be able to opt out. They probably don't know what quality measures their health system is reporting. They're reporting them for them as a group. And if they participate in MIPS, then they would be wise to pick the measures they perform best on so that they can maximize their bonus. They are able to decide, do we want to participate in an ACO or not? And the health system can decide, hey, we are going to have these particular clinicians in our health system at this practice participate in the ACO under this tax ID. And maybe because they perform well on population-based metrics, and this other group, we're not going to have them participate in that. And so it's the span of control of who decides, like, what program are we participating in at a health system. That's not going to be up to an individual clinician unless they're in some kind of leadership role. They may not even be aware of what quality measures are being reported on their behalf.
Got it. Fair enough. What can we learn from commercial insurers and their value-based payment programs?
Yeah, I think that's a great question, because a lot of these things commercial insurers are trying alongside CMS, or even, prior to CMS doing it. I think, there's been a proliferation right now of episode-based payment models at CMS, and commercial insurers in the mid 2000s were experimenting with at least episode-based tracking of quality and costs. And I think the thing I remember from my time there is that, at the end of the day, the thing you end up concluding is, well, we're tracking this physician episodes for knee and hip replacement, or maybe for diabetes care for the year. But the issue is patients don't just have diabetes, or they don't just need a knee or hip replacement. They also might have heart failure or depression. And so that, I think that led insurers and has led CMS towards more of a global population-based approach. I think a good example was the alternative. It was an alternative quality contract or payment contract in Massachusetts. There were some evaluations that came out of that were quite positive. This is a little more than 10 years ago, and so that was an example of an insurer in a particular state experimenting with value-based payment that was positive. But I think it's really important for there to be, CMS as the federal payer, and then private insurers to be learning from each other in this, because they're often touching the same patients, at least over the course of a lifetime. And as we can see, more and more private insurers are actually delivering Medicare as well.
We have another question from Michael Kitchell, who asks, MIPS problem with relevance and control is difficult with small numbers of patients and random variation in patient outcomes. Wouldn't virtual ACOs work better with more population numbers and less random variation because of larger populations?
The question is, I guess, what your goal is. Typically, an ACO is thought of as a local health system that has a span of control. You're talking about physician groups, hospital, post-acute home health providers that patients would visit in their local area, right? If you're talking about these virtual groups, my question is how is it operated at the local level? Because fundamentally, that's where hospitals and clinicians are touching patients, is at the local level. There may be a good reason to do this for pooling risk. The thing that I'm uncertain about is when it comes to actual patient care, touching patients, that occurs at the local level. And so we'd want to be careful that the virtual ACOs aren't just forming virtually in order to cherry pick patients to maximize to do good, right, on the risk-based savings, that there's actually a model for benefiting patient care, which I'm sure some of them have. But I think there are just more information, more data is needed to understand that.
Are specialty care services participating in value-based care? I'm thinking about palliative and hospice care, as described in this question from Yvonne Banks. What role can specialty care play in value-based care, if any?
Yeah, I think that's a really important question, which I think leads me to our other main finding that I didn't mention earlier. When we compared primary care providers, who are about 40% of the clinicians in our population, to specialists, and primary care providers were more likely to participate in ACOs. So specialists were less likely to participate in ACOs and more likely to be QPP exempt. And this has been a big challenge that CMS has, is engaging specialists in accountable care relationships, whether we're talking about specialists like geriatricians or palliative care at the end of life, or specialists like cardiologists, endocrinologists, or even ophthalmologists. I think this is a really critical area, especially because we're talking about the Medicare program, and probably more than half of beneficiaries have at least one major chronic condition, and so they require specialty care. And these are the beneficiaries that also cost Medicare the most, and so it's really critical to engage specialists in ACOs and accountable care patient relationships. I don't know that there's an answer to this question yet. I know the idea was all these non-ACO alternative payment models would engage more specialists, but it really seems that they've just engaged very little of anybody. And so that approach doesn't really appear to be working in terms of engaging specialists. And so I think I would encourage policymakers to think about how ACO programs can be tweaked and redesigned in order to engage more specialists, particularly those who are seeing patients regularly, like cardiologists, for example.
Dr. Kenton Johnston, thank you so much for taking the time. I had a great time talking with you today.
Oh, I had a great time talking with you as well, Rob. Thanks a lot for inviting me to do this.
Absolutely. Thank you to our listeners, and thank you to everyone for participating today. Folks should leave a review, recommend this podcast to a friend, and of course, tune in every week to a Health Podyssey. Thank you, everyone.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about a Health Podyssey.